our disclosures. So single incision slings were introduced to decrease complication rates associated with retropubic and transobturator. And the FDA had requested ongoing studies to determine efficacy of single incision slings. So we decided to compare TVT Abbrevo, which is a modification of the TVTO with shortest sling length but exit points, and the Miniarc, which has been proven comparative to the Monarch at 12-month follow-up. So the objective was to evaluate objective and subjective outcomes of both slings. And inclusion criteria was all female subjects were fair and assessed for stress incontinence who completed conservative therapy without improvement. So exclusion criteria was patients with ISD, significant voiding dysfunction, previous sling, or untreated bladder overactivity. So patients were randomized in blocks of 4 and 8, concealed allocation, so patients didn't know which sling they would have, but the surgeon knew, and assuming an objective cure rate of 90%. So the power we estimated we need a sample size of 79 patients in each arm to detect clinical significance. And the target recruitment was 220, assuming an attrition rate of 15%. Ethics approval was obtained, and the trial was registered. So recruitment took place between 2011 and 2015. All the patients went through all routine preoperative assessment, and data was collected with patient-reported outcome tools and a standardized pro forma, and the slings were performed in standardized fashion, plus minus concomitant surgery. Follow-up was post-op, 6 weeks, 6 months, 12 months, and then yearly after. And at 6 months, they had examination, cough stress tests, and patient-reported outcome tools collected, and a urofluent scan. Follow-up was not always by the surgeon performed the surgery. Subjective cure rate was defined as either negative cough stress test with a comfortable full bladder, and subjective cure was either they did not report leakage when asked, do you leak when coughing, sneezing, or on the ICIQ UI, they didn't tick CE or CE on question 6, which is do you leak when coughing, sneezing, or an exercise. So outcomes were analyzed statistically, and multivariate analysis was performed at 12 months. So this is a consort flow chart. We managed to randomize 246. Of those, 115 received the Miniarc and 120 the TVT Abbrevo. At 6 months, we managed to see 107 of the Miniarc group and 114 of the TVT Abbrevo. And at 12 months, we saw 90 of the Miniarc and 94 of the TVT Abbrevo. Still over 79, so still adequately powered. And I'll go through the repeat slings afterwards. So what that slide shows is that both groups were balanced of age parity, BMI, of demographics. They were also balanced in urodynamics findings and also prolapse. And they were balanced as well on baseline functional outcomes, as well as surgery or patients who had concomitant surgery. Postoperative outcomes, no difference on catheter use after 24 hours, for 24 hours, and no difference on hospital stay more than 1 day on patients who had sling alone. What there was statistically significant is, as expected, it was growing pain postoperatively. The good thing was that the ones on the TVT Abbrevo that complain of more pain, all the pain gradually resolves spontaneously. So at more than 3 weeks, there was no patients with growing pain. And mesh exposure, we had 3 on the TVT Abbrevo group. 2 were excised, and 1 was just covered with a flap. Certain incontinence cure rates. So if we use the ICIQ UI, in both at 6 months and 12 months, TVT Abbrevo seems to be slightly better. At 6 months, was statistically significant if we use the ICIQ, but then it balanced at 12 months. And if we just asked, do you leak when coughing, sneezing, that was not statistically significant at 6 months, but it was at 12 months. On objective cure rate, there was no differences, so same. And similar results on PGII and ICIQ UI and OAB, same with the other patient-reported outcome tools. On multivariate analysis, no differences. So in conclusion, at this current time point, we have assessed 184 women. There's no significant differences in objective cure rates. Subjective cure rates TVT Abbrevo seems to be slightly better, but I doubt that's clinically significant. And both have high subjective and objective cure rate with low complication rate. Groin pain, as showed, was higher TVT Abbrevo, but then it resolved. We had 7 Miniarcs had a successful surgery in the first 12 months. Of those, 2 were Miniarc Pro, which had a different tensioning system, and probably that's why they failed. 4 of them had persistent stress incontinence of the TVT Abbrevo group. 1 was secondary to mesh excision, and 2 had a repeat sling. 1 TVT Abbrevo had to be removed due to pain, 1 loosened, no slings had to be divided. Of the 3 mesh exposures of the Abbrevo group, 2 excised, 1 covered, and OAB no difference. And the trial was still collecting data now at 2 years, 3 years, and so on. Thank you.
Thank you. Thank you very much. Doug.
Hi, Doug Tincello. I have 3 questions, if I'm allowed. I can start with number 1.
Sure.
They're methodological questions, okay? It's a beautifully designed study. I wondered why, when you're doing a randomized controlled trial of a new device versus an established device, you based your power calculation on the anticipated cure rate of the new device rather than the existing device. Because your power calculation, you said the Abbrevo has a 90% cure rate. But surely you should base it on the established device and look at a difference between that and the new one?
No, we calculated the power based on the previous study, the Minimo, which compared Miniarc against Monarch.
Yeah.
So we use the Miniarc.
Yes, but your slides and your abstracts say sample size is based upon a 90% cure of the Abbrevo, not the Miniarc.
No, I think it was the Miniarc.
Oh, that isn't what it says.
Okay.
My second question is, did you realistically expect there to be a 15% difference in cure rate between these 2 devices?
No, but as I say, that's what we used before.
I know.
For a sling, I think 50%, it's reasonable.
But most of the studies comparing sling versus tape don't show a 15% difference. So by doing that, you've made your study underpowered.
They suggest it should be higher, lower?
Well, it should be lower because realistically, a sling versus a sling, the difference in cure rate is going to be probably less than 10%, isn't it?
Yeah. Well,
And my third question is, what is your ethical justification for randomizing 26 patients more than you said you needed at the beginning?
Because we know that it's very difficult to keep the follow-up, and there's a lot of withdrawals, there's a lot of loss of follow-up. So we aim for 220, we managed to get 243. Yeah. So,
but really? Your ethics committee were happy for you over-recruiting into an experimental procedure when you've demonstrated you need 220 to answer your question. So you recruit 26 more. You could say that's unethical in the context of research. That's why we do power calculation.
Yeah, but I don't know if it's unethical or not. You still perform an anti-incontinence surgery, and the patients are fully informed, fully disclosed.
Yeah, but you're randomizing them. You're randomizing your patients to an experimental treatment. By definition, you don't know the risks of your experimental treatment. So of those 26 patients you recruited unnecessarily, you've exposed 50% of them to an unknown risk profile. I would suggest that is probably unethical.
Okay.
Thank you, Doug. Can I ask you, were the procedure performed by different surgeons, and if yes, how many performed?
Yeah, there was one main surgeon, but then there was other surgeons involved. Yeah.
Right. Same level of, I would say, skills.
Yeah.
Okay.
They all had reached the learning curve.
Okay.
At least 20.
And I've seen that you report roughly 45% of groin pain, at least the first assessment.
Yeah.
That is by far much higher than what has been reported in literature so far, even for a TVTO. How would you explain that?
There's different degrees of pain, and sometimes if you ask, do you have any pain? Because there was also 10 on the Miniarc.
Right.
And there's no exit point in the Miniarc.
I agree. So 15% in the Miniarc, yeah.
10 patients reported some sort of groin pain. So I think it's a bit subjective if you ask them, do you have any pain in the groin?
But you do a visual analog scale for that?
No, we just ask.
Okay.
Yeah, we just ask, do you have any pain in the groin?
Okay.
Yeah.
And I think we have to move on. Thank you very much.